Hi, welcome to the IBD Journal Club Fellows Corner. My name is Simon Hong, and today we will be discussing the article titled Incorporating Fecal Calprotectin into Clinical Practice for Patients with Moderate to Severely Active Ulcerative Colitis Treated with Biologics or Small Molecule Inhibitors by Dr. Parambir Dulai and his colleagues, published in the American Journal of Gastroenterology in May. Endoscopic remission is now an important endpoint in the treat-to-target era, yet only 50% of patients on biologics undergo endoscopic disease surveillance. Fecal calprotectin, or FC from here on out, has emerged as an accurate, non-invasive marker of inflammation, yet only 5% of patients undergo FC testing in routine clinical practice. In this study, the authors attempted to answer the question of how well a combination of patient-reported outcomes and a predefined cutoff of FC would perform in predicting endoscopic disease activity in specific clinical scenarios through a systematic literature review. The clinical scenarios and FC cutoffs were determined a priori, and this study used a novel method of pooling individual participant data from the phase 2 and 3 trials of infliximab, golimumab, vedolizumab, and tofacitinib to estimate the population prevalence of endoscopic inflammation across different combinations of rectal bleeding and stool frequency scores. A total of 23 studies containing 2,120 patients were included in the final analysis. And what did they find? For an FC cutoff of less than 50, the overall pooled sensitivity was 82% and the specificity 74% for diagnosing endoscopic healing. A cutoff of greater than 250 had a sensitivity of 76% and a specificity of 79%. These numbers are respectable, but it is when looking at specific clinical scenarios that FC's performance was really able to be improved. In patients with a rectal bleeding score of 0 and a stool frequency score of 0 or 1, an FC less than 50 had a positive predictive value of 90% after induction and 96% after maintenance. Put another way, the false negative rate of FC less than 50 was 5% for induction and 2% for maintenance patients. In the other columns, we can see that the performance of FC decreases when patients have a higher stool frequency score, with corresponding false negative rates of 9 and 12%, and FC greater than 50 is not an accurate test for diagnosing active endoscopic disease. So what about diagnosing moderate to severe endoscopic activity? This next table shows the performance characteristics of an FC cutoff of greater than 250. In patients with rectal bleeding scores and stool frequency scores of 2 or 3, the positive predictive value of an FC greater than 250 was 97% after induction and 95% after maintenance. This corresponds to a false positive rate of 2 to 3%. And again, we see that the performance drops off if FC is below 250 or rectal bleeding is less severe. So how do we put this all together? This study provides some useful guideposts on how to use FC in clinical practice. For patients with no rectal bleeding and stool frequency of less than 3 bowel movements above baseline, an FC of less than 50 is very accurate and can help avoid 60% of colonoscopies with a very low false negative rate. For patients with a rectal bleeding and stool frequency scores of 2 to 3, an FC above 250 is also very accurate and can help avoid 50% of colonoscopies with a very low false positive rate. Overall, this study had strong methodology and impactful findings, but the authors do note some limitations. Data on the more strict definition of Mayo 0 endoscopic healing or on histologic healing were limited, and also given the most commonly reported cutoffs for FC are 50 and 250 in the literature, other cutoffs such as 100 or 150 were unable to be analyzed. In conclusion, this study represents an important step in defining FC's role as a non-invasive marker of inflammation, which is even more critical in the current era of COVID-19, when practitioners are required to use colonoscopies judiciously. FC can be used confidently as a marker of endoscopic disease activity below 50 in patients with resolved rectal bleeding and normal stool frequency, and above 250 in patients with persistent rectal bleeding and increased stool frequency.